guys, welcome to IMG Doctor. Today's video is a continuation of our diarrhea cluster. In this video, we will be discussing few more cases of diarrhea, and all the cases that we'll discuss will be timestamped down below in the description box. So let's start with our first case. So our first case is a 50-year-old female presented with abdominal pain and diarrhea, and there's no history of blood and mucus in stool. She has been taking amoxicillin for bronchitis for 3 to 4 days, and there are remaining 3 more days of her antibiotic course. Vitals are stable, mild dehydration and mild abdominal tenderness is present on examination, and there's no guarding and rigidity. And our tasks are to explain the condition to the patient, tell her the differentials, and tell her about your management plan, including investigations you would do. So as you guys have seen that there is no history taking as your task, which means that you won't have any questions to ask to the patient. These stations can become a very monotonous, one-sided conversation, which is something you want to definitely avoid. So these are just like a counseling station, which means that communication is a very important part, and you need to make sure that your conversation is more interactive, and always check the patient's understanding throughout the station. So the other thing is that when you're explaining the condition to the patient or giving differentials or explaining your management plan, you want to make sure that you go more in detail and be more specific. And hence for this, you need to have a very good knowledge and clear concept about the diagnosis. Because only then you will be able to explain to that condition to the patient. So how do you start this case? You don't want to just go inside and bombard the patient with all the information that you have about the disease, right? So what you can do is that you can ask few questions to the patient, even though this is not a part of your task. And we do this because you want to establish a rapport. And so what questions do you want to ask? Like in this case, the patient presented with abdominal pain and diarrhea. So you can ask few questions related to it. So what you can do is you can ask, like, are you in pain right now? Or how are you doing right now? And then you can ask the patient to scale the pain and offer painkillers accordingly. Okay, so once you're done with that, you can also explain the findings to them, like whatever findings are given in the question. Like in this case, you can mention that on examination your vitals were stable, which is a good thing, but I could notice that there was a mild dehydration, but again provide reassurance that it's easily manageable. Then you can go to your first task, that is giving diagnosis to the patient. So you can say that based on the history and examination, most likely you're having a condition called antibiotic associated diarrhea, which is caused by a bug called Clostridium difficile. And check the patient's understanding. Ask her, like, have you heard about this? Do you have any idea about this condition? And usually people recommend that you don't ask this question, because obviously this is an exam and the patient will tell no, that the person doesn't know about this condition. But what I personally feel is that this is a way of checking the patient's understanding. This is a way of interacting to the patient. So it's better to ask, because AMC is not just testing your theoretical knowledge. It also tests the way we interact with the patient. And I think it's very important that we check the patient's understanding. So each station you need to consider it as a real, clinical scenario, and you need to act like a real doctor. And this will definitely help you pass the station and get a better score. Now we'll have a look at what antibiotic-associated diarrhea is. So it occurs in patients who are in antibiotic therapy. Almost all antibiotics can cause diarrhea, but the risk is higher when the person is taking these antibiotics such as aminopenicillins, cephalosporins, and clindamycin. So what's happening is that when the person is on antibiotics, it disrupts the normal microflora of the gut. And this results in overgrowth of microorganisms that induce diarrhea. And Clostridium difficile is reported as the major enteropathogen of antibiotic-associated diarrhea. And Clostridium difficile, it produces 2 potent toxins that cause mucosal damage and inflammation of the colon. So how can you explain this to the patient? So how you start is that you can just draw a picture showing, the large bowel, the small bowel, and explain the basic digestive tract. Okay, and what's happening is that there is a balance of good and bad bacteria in your GI tract. And when the antibiotic that you're taking, so in this case it's amoxicillin, so amoxicillin, it has caused a disruption of this balance, and hence it has resulted in overgrowth of a bacteria called Clostridium difficile. Now, this is a bad bacteria because it produces toxins that attack the lining of your bowel wall, and that is the reason you're having diarrhea, you're having tummy pain. So this is how you can explain to the patient in simple language. Not all patients who are on antibiotic therapy develop Clostridium difficile infections. There are certain risk factors that make the person more vulnerable or increases the risk to development of Clostridium difficile infection. So these are long hospital stay, recent antibiotic use, older age, immunosuppressive therapies, cytotoxic therapy, renal impairment, prior gastrointestinal surgery, severe underlying comorbid conditions, and gastric acid suppressive therapy. So in our case, the patient is 50 years old and has recently been using amoxicillin. So these are the risk factors. And in exam, try to look for these risk factors in the clinical scenario so that you can explain it to the patient when you're explaining the condition. Now, coming to symptoms, it usually occurs 5 to 10 days after commencing antibiotic therapy, and the spectrum of Clostridium difficile infection can range from mild diarrhea to fulminant pseudomembranous colitis to severe complications such as toxic megacolon, perforation, and shock. So in mild cases, the diarrhea is usually watery but may occasionally be bloody. The other symptoms include fever, loss of appetite, nausea, and abdominal pain. Now, any of these following features are more suggestive of a severe Clostridium difficile infection. These are fever with rigors, when there is a hemodynamic instability, when there is peritonitis or evidence of bowel perforation, ileus, or toxic megacolon. And in our case, because the patient's vitals were stable and only there was evidence of mild dehydration, and even on per abdominal examination, there was only mild tenderness and absence of the rigidity and guarding. So in our case, it's most likely that the patient is just having a mild to moderate infection. Now, coming to investigations, you need to do a full blood count where you can expect a raised WBC count. You need to do urea, creatinine, and electrolytes for dehydration. You need to do albumin where you can expect a low albumin level. And then you need to do a stool test. It should be performed only on unformed stools. And here you need to do it for detection of Clostridium difficile toxin in a cell-based cytology assay or toxigenic culture of Clostridium difficile obtained from stool. And this is considered as the gold standard for the diagnosis. And then we have different enzyme immunoassays to detect toxins A and or B. And similarly, immunoassays to detect Clostridium difficile glutamate dehydrogenase. PCR-based assays to detect the Clostridium difficile gene toxin. And then we have imagings like abdominal CT, flexible sigmoidoscopy, and colonoscopy. Now, imaging, it's not routinely done for everyone. So to the patient, you can explain it in a very simple language that, to confirm the diagnosis, we need to do certain tests. So in blood test, we will be doing the full blood count, urea, creatinine, electrolyte, albumin, and we need to do the stool test. So in stool test, just tell them that we need to do a stool culture, okay, to detect the Clostridium difficile toxin. We will need to do certain immunoassays to detect the toxins and to detect Clostridium difficile glutamate dehydrogenase. So try to keep it very simple. And then in case of imaging, what you can say is that, we might also need to do some CT scan and colonoscopy, but it will be decided by the specialist once he assesses you. So now coming to treatment, we need to stop the antibiotics. Tell the patient that we will be stopping amoxicillin, and then we will give you another antibiotic that is specifically targeted to kill the bacteria that is Clostridium difficile that is responsible for your diarrhea. So in mild to moderate cases, you need to give is metronidazole. And for severe cases, you can go for vancomycin. And the course of antibiotics is usually for 10 days. And then apart from that, encourage the patient to drink plenty of fluids, and also tell them that it will take 2 to 3 days for the diarrhea to subside. So meanwhile, drink plenty of fluids and practice good hand hygiene with soap and water in order to prevent the transmission of disease. And you can follow him up once the results are out. So that's it for this case. Now coming to the next case, we have a 35-year-old female who complains of chronic diarrhea for 3 months. Your task is to take history, diagnosis, and give differentials. So as you can see here, we do not have PFI as a task. So you need to spend a good 6 minutes in history taking, and make sure you ask as many questions as you can to rule out your differentials. So when you ask history about diarrhea, the duration is of 3 months. It is on and off, and the patient complains of 3 to 4 times in a day. The stool is foul smelling, watery, mushy, and the patient also complains of stomach cramps and loss of weight. Then ask about the past history, family history, travel history, and SADMA questions. Here, travel history is very important. You need to ask in detail about the patient's journey, like when, where, and what did the patient do. Also look for behaviors regarding eating and drinking that can be a potential source of infection. And in this case, the patient went to Bali 4 months ago and had street foods, and this is the positive finding for this case. Then for the differential diagnosis, these are the causes of chronic diarrhea, and you need to ask specific questions for all of these differentials so that you can rule them out, and you can mention them in your second task. Now this is a case of Giardiasis. So you have positive findings like chronic diarrhea for 3 months, loss of weight, stomach cramps, and a positive travel history. So when you explain it to the patient, tell them that it is an infection of the bowel caused by a parasite called Giardia lamblia, and the cause is due to drinking of contaminated water or eating contaminated food. And you can correlate it with the patient's finding, like when the patient went to Bali, he had consumed street foods, and that could be the potential source of infection. And then you mention about the symptoms. Again, instead of mentioning all the clinical features of giardiasis, what you can do is correlate it with the patient's condition. So you can just tell them that, because the infection is in your bowel, that's the reason you're having diarrhea and stomach cramps. But in order to confirm the diagnosis, you need to still do a few more investigations. But do not go in detail about the investigations, because it's not your task. And if you tell them about the investigations, the examiner will stop you and they'll tell you stick to your task. So better to move on to your next task, that is giving differentials. So mention all the causes of chronic diarrhea, and just mention a few words about how you rule them out, and conclude your station. Now, diagnosis and treatment is not a part of this task, but I've mentioned this slide just for your further information. So when it comes to diagnosis, you need to do a stool microscopy to look out for cysts and trophozoites in stool. Then there are also ELISA or direct immunofluorescent antibody methods to detect antigen in the stool. Now coming to treatment, we give the antibiotic therapy, metronidazole or tinidazole. And giardiasis, it's not a notifiable disease in Victoria. So that's it for this video. I hope it was useful. If you have any queries, please comment below. Thank you so much for watching.